You can think of the esophagus as a 25 to 30 centimeter long tube that has a wall composed of 4 layers. The esophageal mucosa is made of different layers. There's an inner stratified squamous epithelium layer, the submucosa, a muscular layer that's made of skeletal muscles in the upper third, smooth muscle in the lower third, and a combination of 2 in the middle, and finally an outer layer of connective tissue called adventitia. At the top and bottom of the esophagus, there are the upper and lower esophageal sphincter, respectively. Both relax during swallowing to allow the passing of food or liquids propelled by peristaltic contractions. Additionally, the lower esophageal sphincter prevents acid from refluxing back into the esophagus between meals. There are 3 main ways to evaluate the esophagus. First, there's an upper gastrointestinal tract radiography, or a barium swallow, which uses orally ingested barium as contrast for an X-ray of the esophagus, stomach, and duodenum. Second, there's an upper endoscopy, which is when a flexible tube with a camera is sent through the mouth to visualize the esophagus, stomach, and duodenum, and take a biopsy if needed. Third is esophageal manometry, which is where a pressure-sensitive catheter is inserted through the nose and sent into the esophagus to measure the strength of peristaltic contractions and the esophageal sphincter's contractions during swallows. There are 2 types of esophageal manometry. In classical manometry, there are 4 to 8 pressure sensors placed at different levels of the esophagus, and a normal reading looks something like this. In high-resolution manometry, there are more pressure sensors, and the reading is color-coded and looks like a surface map, where red indicates the strongest contractions and blue indicates the weakest contractions. So that looks something like this. There are a number of esophageal conditions that can be treated surgically. First, there's Zenker's diverticulum, which is where the esophageal mucosa and submucosa of the esophagus slide through an area of muscle weakness right above the upper esophageal sphincter, forming a pouch-like structure sticking out from the wall of the esophagus. This causes symptoms like intermittent oropharyngeal dysphagia, as well as halitosis or bad breath, as food accumulates in the pouch. A Zenker's diverticulum is usually diagnosed with a barium swallow, and an upper endoscopy is not recommended because it can cause perforation. Typically, the Zenker's diverticulum is surgically resected. This procedure is called diverticulectomy, and it's generally done with cricopharyngeal myotomy. The technique involves neck surgery to resect the diverticulum and incise the cricopharyngeus muscle between the esophagus and the diverticulum. The reason for the myotomy is that the upper esophageal sphincter dysfunction could have led to the diverticulum. Increasingly, open surgery has been replaced by endoscopic diverticulotomy and myotomy with a rigid or flexible endoscope. Next up is achalasia, and that's where esophageal peristalsis is ineffective at moving food and liquids through the esophagus. In addition, the lower esophageal sphincter doesn't completely relax during swallowing, so that leads to food accumulation and dilation of the distal esophagus. Symptoms include progressive dysphagia for both solids and liquids, regurgitation of undigested food, chest pain, and weight loss. Over time, it can lead to severe dilation, or megaesophagus, which is when the esophagus has a diameter of over 6 centimeters. On a barium swallow, the esophagus is dilated and has a narrow lower sphincter. This is called the bird's beak sign. An upper endoscopy should also be done to check for esophageal cancer. High-resolution manometry is the best way to confirm achalasia. It can show absent peristalsis and high pressure at the lower esophageal sphincter. The most effective option is called a Heller laparoscopic myotomy. That's where a small cut is made in the lower sphincter to relieve the pressure, and this usually works for over 10 years. Late recurrence is generally associated with fibrosis. Sometimes, anti-reflux fundoplication surgery is done at the same time to prevent development of GERD. That's where the fundus of the stomach is wrapped or plicated around the lower end of the esophagus and is stitched in place, reinforcing the closing function of the lower esophageal sphincter. There are 3 main types of fundoplication. Nissen fundoplication, also called a complete fundoplication, in which case the fundus is wrapped the entire 360 degrees around the esophagus. In a door or anterior fundoplication, the fundus is laid over the top of the esophagus, while in a toupee or posterior fundoplication, the fundus is wrapped around the back of the esophagus. Surgery for achalasia is generally accompanied by either a door or toupee partial fundoplication, which is less likely to worsen the dysphagia than a Nissen wrap. Another option is a peroral endoscopic myotomy, or POEM, which is where an incision is made in the esophageal mucosa. An endoscope is passed through that incision and into the esophageal submucosa, and is tunneled through the submucosa distally into the gastric cardia. First, a cut is made in the esophageal mucosa roughly halfway down the esophagus. Then, the submucosal tunnel is made, and the scalpel is passed through the endoscope and through this submucosal tunnel. Once the circular fibers of the lower esophageal sphincter are encountered, they are divided all the way down onto the first part of the stomach to functionally weaken the sphincter. Finally, the submucosal flap is closed using clips or sutures, also placed through the endoscope. When a POEM is done, a fundoplication is not usually done, so it can result in GERD. Now, individuals over age 40 are considered high risk for myotomy procedures, so they usually undergo a pneumatic dilation. That's where a balloon is inserted through an endoscope into the esophagus at the level of the lower esophageal sphincter, and filled with air for about 45 seconds to stretch out the muscle layer. Pneumatic dilation is less invasive than surgical myotomy, and works for up to 2 years before the efficacy begins to wane. The dilation can be repeated, but the success rate begins to fall off after a third dilation. That's because there's a progressive fibrosis or scarring of the lower sphincter with each dilation. Individuals over age 65 are poor candidates for myotomy and pneumatic dilation, so they're often treated with botulinum toxin that's injected directly into the lower esophageal sphincter through an endoscope. Botulinum toxin inhibits the excitatory acetylcholine-releasing neurons that are responsible for the high, smooth muscle tone in the lower esophageal sphincter. The result is a decrease in lower esophageal sphincter pressure, but it typically only works for up to a year. The least effective therapy option for achalasia are medications like nitrates and calcium channel blockers, like nifedipine. Both calcium channel blockers and nitrates are short-acting, so typically sublingual nifedipine is taken 30 to 45 minutes before meals, and sublingual isosorbide dinitrate is taken 10 to 15 minutes before meals. For end-stage achalasia, sometimes the only effective option is an esophagectomy, so removal of the esophagus, plus gastroplasty or coloplasty, which is reconstruction of the stomach or colon, respectively. With diffuse esophageal spasm, peristaltic contractions of the esophagus are intermittent and uncoordinated, which leads to ineffective contractions. In most cases, there's also incomplete relaxation of the lower esophageal sphincter, just like with achalasia. Individuals often have retrosternal chest pain and intermittent dysphagia for both solids and liquids, but they rarely have regurgitation. On a barium swallow, the esophagus will have a corkscrew or rosary bead appearance. Again, high-resolution manometry is the gold standard, and it shows uncoordinated high-amplitude peristaltic contractions. Because diffuse esophageal spasm is intermittent, these findings might only be seen on some test swallows or on some days of testing. Treatment options are similar to achalasia, but the order is reversed. Calcium channel blockers and sublingual nitrates are a first-line treatment because they're more effective. In severe cases, pneumatic dilation and botulinum injection therapy can be used, but they're only short-term measures. In extremely rare cases, laparoscopic myotomy may be considered. Next, there's GERD, which occurs when the resting pressure of the lower esophageal sphincter is below 10 millimeters of mercury, because that allows gastric acid to flow into the esophagus. GERD causes heartburn and regurgitation, as well as retrosternal chest pain, dysphagia or difficulty swallowing, persistent coughing, voice changes, halitosis or bad breath, dental erosions, or even nighttime asthma symptoms. In addition, some individuals have weight loss, iron deficiency anemia, anorexia, odonophagia or painful swallowing, and upper gastrointestinal bleeding, all of which are symptoms that can be seen in esophageal cancer. In these situations, an upper endoscopy and biopsy can be done. One complication of GERD is Barrett's esophagus, which is where stratified squamous epithelium of the distal esophagus is replaced by metaplastic columnar epithelium. That's the same cellular layer found in the intestine, and it contains goblet cells that secrete mucus. This metaplastic columnar epithelium in Barrett's esophagus is considered a premalignant lesion. In Barrett's esophagus, the upper endoscopy shows a change in the epithelium at least 1 centimeter above the gastroesophageal junction. Over time, the metaplastic cells of Barrett's esophagus start to become dysplastic. The cells become bigger, pleomorphic, and proliferate quickly. Based on cytologic abnormalities, like the size of the nuclei and the rate of proliferation, the tissue is categorized as a low-grade dysplasia or high-grade dysplasia. If the tissue has mutated to the point where the cell division is dysregulated, then the growing cell mass can break through the tissue boundaries and invade neighboring tissues. And at that point, it's called esophageal cancer, specifically adenocarcinoma. Ambulatory 24-hour esophageal pH monitoring is used to confirm the diagnosis of GERD in individuals that are unresponsive to medical therapy or have atypical symptoms. This is a minimally invasive technique in which a flexible catheter with a pH sensor is inserted through the nose and down to the distal esophagus. The outer part of the catheter is connected to a monitor that's connected to the individual, like on their belt. After 24 hours, the data is analyzed and a Demeester score is calculated based on how many times the pH dropped below 4, and the number and length of reflux episodes based on symptoms. A score above 14.7 is suggestive of GERD. Treatment of GERD starts with lifestyle and dietary changes, like weight loss in overweight and obese individuals. The goal is a body mass index between 18.5 to 25 kilograms per square meter. In addition, it's ideal to raise the head of the bed at least 6 inches to prevent nocturnal GERD symptoms. Also, it's best to not eat within 2 hours of going to sleep, and to eliminate spicy foods and caffeinated drinks. In individuals with less than 2 episodes of acid reflux per week, without complications on upper endoscopy, the first medication used is a low-dose histamine 2 receptor antagonist, or H2RA, which decreases the production of gastric acid. If the symptoms haven't improved after a few weeks, then the H2RA dose is increased. And then if that doesn't help in a few weeks, the H2RA is stopped, and a proton pump inhibitor, or PPI, such as omeprazole, is given, and the dose is slowly increased as needed. If symptoms are controlled only with a high dose of PPIs, then a Nissen fundoplication may be done as a laparoscopic anti-reflux procedure. And remember, that's where the gastric fundus is wrapped completely around the distal esophagus, strengthening the lower esophageal sphincter. In individuals with more than 2 episodes of acid reflux per week, or erosive esophagitis, treatment begins with the standard dose of a PPI for 8 weeks. If symptoms disappear, the dose of PPI is gradually decreased. If PPIs were taken for more than 6 months, then the dose is decreased gradually and replaced by H2RA. If the symptoms recur, PPIs are restarted with the lowest dosage that last controlled the symptoms. For individuals diagnosed with erosive esophagitis that is severe, a repeat upper endoscopy should be done after 8 weeks of medical therapy to see if there's evidence of healing and to rule out Barrett's esophagus. In individuals with Barrett's esophagus, treatment begins with the standard dose of a PPI, which is increased until symptoms of GERD are controlled. Barrett's esophagus can develop into esophageal adenocarcinoma. That's why, if the initial biopsy showed no dysplasia, then the upper endoscopy and biopsy is repeated after 3 to 5 years. If the initial biopsy showed indefinite dysplasia, then the PPI dose is increased and the upper endoscopy and biopsy is repeated after 2 months. If the initial biopsy showed low-grade dysplasia, localized high-grade dysplasia, or intramucosal carcinoma, then the individual typically has an endoscopic resection of the esophageal mucosa and submucosa, and then radiofrequency ablation of the affected tissue. Finally, in individuals with extensive high-grade dysplasia, an esophagectomy may be needed, which is the surgical removal of the esophagus. Now, GERD can also lead to formation of a benign esophageal stricture. That's where stomach acid and other irritants damage the esophageal lining, leading to inflammation with esophagitis and scar tissue, which causes the esophagus to narrow. Other causes include caustic ingestion, eosinophilic esophagitis, and radiation therapy. With a benign esophageal stricture, individuals have progressive dysphagia for solids, odonophagia, heartburn, and weight loss. On a barium swallow, the stricture causes the flow of barium to get obstructed, so that it looks like a thin string of contrast going through the esophagus. On an upper endoscopy, the esophageal stricture and the narrowing of the lumen can be directly seen. Treatment of a benign esophageal stricture is pneumatic dilation, and repeated dilations are sometimes needed. If pneumatic dilations don't resolve the symptoms, then a stent may be placed at the site of the stricture. Now, if there's a tumor within the esophagus, then it can also lead to a narrowing of the lumen. Like in benign esophageal stricture, symptoms include progressive dysphagia for solids, odonophagia, heartburn, and weight loss. But there may also be upper gastrointestinal bleeding, which can lead to iron deficiency anemia. Cancer in the lower esophagus is generally adenocarcinoma, and it may be associated with GERD, while cancer in the upper esophagus is generally squamous cell carcinoma, which is associated with smoking. On the barium swallow, again, the flow of barium gets obstructed, but because tumors are often irregular in shape, the narrowing of the lumen will be irregular as well. On an upper endoscopy, a tumor mass can be seen within the esophagus, and there are usually ulcers and erosions as well, and this can be confirmed on a tissue biopsy. To stage the tumor using the TNM system, which is tumor, node, and metastasis, other studies have to be done, like endoscopic ultrasonography, a CT scan, and an MRI scan. Based on the TNM system, esophageal carcinoma has 5 stages, from 0 to 4. 0 meaning only the epithelial wall of the esophagus is infiltrated, and 4 meaning there are distant metastases. Usually, in the first 3 stages of esophageal carcinoma, 0, 1, and 2, the tumor can be surgically or endoscopically resected. However, in stage 3, the tumor is resectable only if it hasn't invaded important structures, such as the aorta, the trachea, or the spine. If it has invaded those structures, then chemoradiation therapy is indicated. Stage 4 is also unresectable, and only chemoradiation is used. Now, as a quick recap, there are a number of esophageal disorders that are managed surgically. With Zenker's diverticulum, individuals have dysphagia and halitosis, and treatment is diverticulectomy with cricopharyngeal myotomy. With achalasia, individuals have progressive dysphagia for both solids and liquids, and a high-resolution manometry is the gold standard for diagnosis. Treatment primarily relies on Heller laparoscopic myotomy that works for about 10 years, pneumatic dilation that works for about 2 years, and botulinum toxin injections that work for only a few months. With diffuse esophageal spasm, individuals present with retrosternal chest pain, intermittent dysphagia for both solids and liquids, and again, high-resolution manometry is the gold standard for diagnosis. Treatment in this case mainly relies on calcium channel blockers and nitrates. In severe cases, pneumatic dilation and botulinum toxin therapy can be used, and in extremely rare cases, laparoscopic myotomy can be done. In GERD, esophageal manometry is indicated in individuals with retrosternal chest pain and dysphagia to rule out functional disorders. An ambulatory 24-hour pH monitoring is indicated to confirm the diagnosis of GERD in individuals with atypical symptoms who are unresponsive to PPIs. In addition, an upper endoscopy is indicated in individuals with atypical symptoms or alarm symptoms to detect esophagitis, esophageal stricture, Barrett's esophagus, and adenocarcinoma. Individuals with Barrett's esophagus should get a biopsy to evaluate the grade of dysplasia. Low-grade dysplasia, localized high-grade dysplasia, or intramucosal carcinoma get an endoscopic resection of the esophageal mucosa and submucosa and then radiofrequency ablation of the affected tissue, while extensive high-grade dysplasia may need an esophagectomy. With benign esophageal strictures, treatment is pneumatic dilation. In individuals with adenocarcinoma or squamous cell carcinoma, treatment is indicated depending on the TNM stage. Stages 0, 1, and 2 of esophageal carcinoma are surgically or endoscopically resected. Stage 3 carcinoma is resectable only if it hasn't invaded important structures, such as the aorta, the trachea, or the spine. If it has invaded those structures, then chemoradiation therapy is indicated. Stage 4 is also unresectable, and only chemoradiation is usually used.